Hi guys, my name is Melissa Peters and I am an occupational therapist and I am a professor at Baker College in Allen Park, Michigan. All right. This semester, one of the things that we're covering is the brachial plexus, the dreaded brachial plexus. But as OTs, we have to understand it because it's what gives us all of our nerve innervation, so it stimulates our muscles and it gives us sensation throughout the arm. Okay, so we have to understand it. And it's not to be feared. And that's why I'm doing this today, is to let people know how easy it is to break down the brachial plexus, understand the flow, so that we can be really good clinicians, all right? Because we have to understand how everything is coming together in order to come up with really good interventions and understand how to help people, move through their problems. So what we're going to do is we're going to break down the first step, which is just drawing the brachial plexus. So easy, okay? It's going to be 3 Y's, all right? 3 Y's, 2 M's, and 1 X. It's that simple, okay? So we start with our nerve roots. We know C5, C6, C7, C8, and T1. So we're going to draw this together, all right? Have your piece of paper and a pen ready, and here we go. We have C5, C6, C7, C8, and T1. These are the roots. All right, R standing for roots. And we'll go over some easy mnemonics to help you kind of remember how all this comes together. But again, C5, C6, C7, C8, and T1. Those are our spinal roots that everything starts with. So I said we were going to draw 3 Y's. Here we go. All right, 2 of those Y's go in the same direction. There's 1 Y, and then down here is my second Y. So you see, so C5 and C6 come together to make 1 Y. C8 and T1 come together to make my second Y. My third Y just faces the opposite direction, just going this way, okay? So there you have it, 3 Y's, done, easy. The next letters we're going to draw are going to be M's. We're going to make 2 M's, one of which is going to feel kind of like an optical illusion, but you'll understand what I'm talking about, okay? So ultimately, I'm just going to come here, and I'm going to make an M. I like to think of my 2 M's as standing for musculocutaneous nerve and median nerve, okay? Since those are the 2 main branches that kind of extend through the arm off the brachial plexus. So here's my 1 M, all right? I have 1 M here. The other one, I'm just going to input up here. So again, kind of like an optical illusion, you could say, all right, is my second M. So you can see I have 1 M here, and I have 1 M here. If you do this with a piece of paper, it's easy if you kind of rotate the paper, draw your 2 M's so that you can see them, and then you can kind of go back. All right, so I have my 2 M's. So again, 1, 2, 3 Y's, followed by 2 M's. All right, I said there were going to be 3 letters. My last letter is an X. Here it is. Here's my X. That's it. There's my X. So again, 3 Y's, 1, 2, 3, 2 M's. I have this M here, and I have this M here. And then I just finished off by making an X. That is ultimately how you will draw your brachial plexus. Everything else comes and builds off of this, but this is your foundation. Once you have this, everything should start moving in a way that makes some sense, okay? Now, these are the spinal roots, C5, C6, C7, C8, and T1. Say them again to yourself. C6, C7, C8, T1. Those spinal roots come together to make 3 trunks, okay? And here we have our trunks. We have an upper, we have a middle, and we have a lower trunk. An upper trunk, a middle trunk, and a lower trunk. And there they are. Okay? So again, the roots come together to make trunks. No problem. Each one of those trunks is going to branch off. You're going to see a fork in the road. And if you follow it, you'll see there's only 1 of 2 ways to go. Those are called divisions. Okay? Those are our divisions. Okay? And if you see, let's follow this, okay? If I'm following this line this way, I can either continue to go this way or I can go this way. That's the fork in the road. If I'm following that middle trunk, I can either go this way or I can go this way. There's the two divisions. If I'm following here, I can either go this way or I can go this way. Again, forks in the road. They're all called anterior, posterior. The divisions are either going in anterior or a posterior direction. So again, we follow this way. Here is my anterior division, and this way would be my posterior division. Simple enough. If I'm going this way, this is my anterior division, and this is my posterior division. Okay, and I hope you're just following along, drawing this as we go. That's how you learn. Learning is not a spectator sport. All right, you have to put it in motion. Draw it with me. And then finally, we have this lower chord, and again, we have our here and here. Now, just like everything, sometimes things want to be difficult. So in this, the anterior and the posterior division have actually swapped places. So we should just thank the brachial plexus for just making us have to think a little bit. All right, so this is just reversed. This is actually my anterior division, and this is actually my posterior division. Okay, so no big deal. That bottom one is just flip-flopped. Okay, now after we have those divisions, roots, trunks, divisions, we have chords in the brachial plexus, and we are almost there. We are almost there. Once we have chords, now instead of going upper, middle, and lower, we have a lateral, posterior, and a medial chord. Okay, up here is our lateral chord. Okay, our lateral chord. Down here is our posterior chord. All right, and then finally down here is our medial chord. Our medial chord. Okay, again, lateral chord, posterior chord, and the medial chord. Once you understand the end of the brachial plexus, sometimes you can work backwards to really orient yourself, because if you know things about the ulnar nerve and how it travels down the arm, you know that it's on the medial side of the arm, so you could then trace it back to kind of that medial location. So sometimes you can go this way with your knowledge or reverse it and kind of come back the other way. That can be helpful. So again, lateral chord, posterior chord, and medial chord of the brachial plexus. The last part we have are our final nerve branches. Okay, our final branches. And we have three main ones that go through the arm: musculocutaneous, median nerve, radial nerve, and ulnar nerve. There's the four big ones that travel through the arm. In a separate video, we will break down those tracks. But for now, we're thinking about how this all kind of comes through within the brachial plexus itself. Okay? So our main branches, we have musculocutaneous nerve up here coming off of that lateral cord. Musculocutaneous nerve. Okay? Now, when we drew that big M earlier, I love that because ultimately that big M just becomes your median nerve. Okay, that first big M, median nerve. Easy, no problem. All right. This guy here coming out that posterior cord, he continues off as your radial nerve. Okay, the radial nerve, who just we know dominates the posterior areas of the arm and forearm. It's great. Radial nerve. And then finally down here, all right, we have our ulnar nerve. Ulnar nerve. And again, we know this is coming off that medial cord, and it travels to the medium side of the arm, or the medial side of the arm, so it makes sense that that would be the case. Okay, so the four big branches: musculocutaneous nerve, median nerve, radial nerve, and ulnar nerve. Okay, not to be feared, easy. So this is ultimately how we get to that. Now, what we have to understand as good therapists, skilled therapists, is that there's a lot of other musculature that is stimulated by the nerves within the brachial plexus. It's not just these four. It'd be great if it was, but it's not. We have nerves that innervate our scapula, which is one of the first things we assess in our patients. Because before we even go into our functional range of motion screen, where we're testing for shoulder flexion, shoulder abduction, external rotation, internal rotation, horizontal, AD and abduction, before we start even going there, we need to assess for scapular stability and mobility. Because if we don't have good scapular stability and mobility, we don't have glenohumeral rhythm. And that's something that we need to know. So we have to know what muscles innervate the scapula. It's one of the first places we start. The scapula reviewing does elevation, depression, protraction, retraction, and it allows for upward rotation. Okay? So we have to start putting in some of these other little nerves. Not hard, very easy. The first one we're going to talk about, coming right off of the C5 nerve root, is your dorsal scapular nerve. DN. Dorsal scapular nerve. Write it down. This nerve innervates your rhomboids, both. Rhomboids major and minor, which allows for scapular retraction. Dorsal scapular nerve. Okay? Now, C5, C6, and C7. Okay? These guys combine. They give off nerve roots to give us our long thoracic nerve. Sometimes you'll hear people say C5, C6, C7 are your wings to heaven. It's not because you're going to die. It's because if your long thoracic nerve is having difficulties, it can't stimulate your serratus anterior muscle. This muscle here, which allows for scapular protraction. So if I can't protract, my scapula is going to start winging behind me. All right? So that's where you have C5, C6, C7, wings to heaven. All right? If you don't have that long thoracic nerve innervating your serratus anterior, your scapulas are going to wing back. We don't want that. Okay? So, easy enough. Now, we start to come up here, and some nerves that we have coming off of that upper trunk are going to be nerve to subclavius. Nerve to subclavius is innervating the subclavius muscle, which is right underneath your collarbone, right, your clavicle, and it allows for depression of the clavicle. That's all we need to know about that muscle and nerve to subclavius. Okay, moving on. All right, we have nerve to subclavius there, and we also have our suprascapular nerve. So we're still staying within the scapula. We know we have those rotator cuff muscles, which are infraspinatus, all right, supraspinatus, teres minor, and subscapularis. So this suprascapular nerve innervates your supraspinatus muscles and your infraspinatus muscles. Supraspinatus muscles allow for this internal rotation, all right, medial rotation. Infraspinatus is going to allow for external rotation, okay, or again, external rotation, rotator cuff muscles, okay? So again, suprascapular nerve. Now we're going to dive into those cords, that lateral cord, posterior cord, and medial cord. Off of the lateral cord, we have lateral pectoral nerve. Lateral, let me make it better L here. Lateral pectoral nerve. This nerve innervates pectoralis major, okay? Which we know we need to have for shoulder flexion, right? Shoulder adduction, pushing motions. So if you were trying to vacuum something, that's pushing against resistance. That needs a lot of pectoralis major strength. And with shoulder extension, it fires as a stabilizer to co-contract. So it really would be involved in that kind of a motion. Those pushing and pulling motions require a lot of that pectoralis major muscle. So we really want that to be firing up. If we have a lateral pectoral nerve, what do you think we might also have? A medial pectoral nerve, right? So down here off of that medial cord, we are going to find that medial pectoral nerve. The medial pectoral nerve innervates pectoralis major and minor muscles. All right, innervates both pectoralis major and minor. Okay, so pectoralis major is innervated by both lateral pectoral nerve and medial pectoral nerve. Pec minor is only innervated by that medial pectoral nerve. Okay? Let's stay down here in this medial cord because there's two other nerves that come off. These two nerves, easy, easy. They are the only two nerves coming off the brachial plexus that only do sensation. They're not innervating muscles at all. They're just giving skin sensation. We have our medial, write it down, brachial cutaneous nerve. Medial, brachial cutaneous nerve. All right, let's think about this. Medial, on the medial side of the arm, brachial cutaneous nerve, innervating the skin on the medial side of the arm. Okay, medial side of the arm. And it makes sense because in this medial side, that median and ulnar nerve are traveling down, but they're not giving intervention yet. They're still just traveling before they really hit town and come alive. So we needed someone to give us some sensation over here. And it isn't musculocutaneous nerve because that's a little bit more on the anterior side. It's this medial brachial cutaneous nerve. Now, if there's a medial brachial cutaneous nerve, we also have a medial antebrachial cutaneous nerve, which is just doing the same exact thing in the forearm. Down here, the skin on the medial aspect of the forearm is innervated by this medial antebrachial cutaneous nerve. Medial antebrachial cutaneous nerve. That is the only three that come off that medial cord. All right? We only have this posterior area to worry about. That's it. That's it. We are almost there. All right? So, here we have our upper subscapular nerve. Because going back to the scapula, we talked about supraspinatus and infraspinatus. But we haven't talked about the subscapularis muscle, which allows for internal rotation. Okay? Internal rotation is primarily done by this subscapularis muscle, which is going to be innervated by two nerves. And again, if you have an upper subscapular nerve, odds are you're going to have a lower subscapular nerve. All right? Just an FYI. So that upper subscapular nerve innervates that subscapularis muscle to help us with medial rotation of the scapula, of the shoulder, medial rotation. All right? Next to this guy, this is called thoracodorsal nerve. Thoracodorsal nerve. All right, I just wrote TN. Thoracodorsal nerve. Innervates latissimus dorsi. Here comes a powerhouse muscle within the back. That latissimus dorsi muscle gives us our shoulder extension. Strong muscle. That's why we can do extension. We have a lot of strength with this motion because of that thoracodorsal nerve innervating latissimus dorsi. It also helps us with shoulder adduction, coming together. So people who are doing pull-ups and chin-ups, the reason they can do those really hard exercises is because of that latissimus dorsi muscle. It's big and it's strong. That's coming in from thoracodorsal nerve is innervating that. All right, if we had an upper subscapular nerve, we then have a, here it is, lower subscapular nerve, which is, again, innervating that subscapularis muscle that we just talked about. It just gets innervated by two nerves, upper subscapular nerve and lower subscapular nerve, okay? Innervates that subscapularis muscle within the scapula to allow for medial rotation or internal rotation. Internal rotation, okay? I like to remember this because remember we have our latissimus dorsi that's innervated by this thoracodorsal nerve. Anytime you've got latissimus dorsi working, you've got that teres major working. All right? They work together. And this is right next door to that. So this lower subscapular nerve also innervates teres major. And if you think about that, again, latissimus dorsi, teres major are always working together. So they might have different innervations, but they're located right next to each other. Thoracodorsal nerve, latissimus dorsi, lower subscapular nerve also innervates that teres major. Okay? We're doing good. We're doing good. All right? The last big nerve here without going into those final four is this axillary nerve. Because the one area we really haven't talked about that we're assessing for right out of the gate is shoulder. We need shoulder flexion, right? Again, shoulder abduction, external rotation, internal rotation. All right, we need our shoulder extension, all those things. Well, we have our deltoid muscle. that is innervated by our axillary nerve. All right, so again, deltoid, we have our anterior deltoid for shoulder flexion. We have our middle deltoid for shoulder abduction. We have our rear deltoid for shoulder extension. The deltoid will also assist with our internal and external rotation, but prime movers, again, are flexion, abduction, shoulder extension. Okay? And again, we test for that when we do our functional range of motion scan right at the beginning. It's one of the first things we assess with our patients. So to not know what nerves are innervating what muscles and what the muscles are supposed to be doing will impair our ability to be really good practitioners and understand the mechanism. So if you know that someone had an axillary nerve injury, all right, or has damage within the axillary nerve, you now know their shoulder motions are going to be impaired. The severity would depend on the injury. I don't know. It could be severed to no function, all right, to just greatly damaged. All right, so just a clinical reasoning question. Notice that a lot of muscles don't help us with shoulder abduction. That's really, for the most part, only your axillary nerve, right? So you would really be impaired for shoulder abduction if you had axillary nerve damage. Whereas for shoulder flexion, remember, you had the pectoralis muscles coming along. You actually have your coracobrachialis muscles. So you would still have some ability to do some shoulder flexion. And shoulder extension, you have help from what? Latissimus dorsi, teres major. So you would still have some abilities, but that shoulder abduction, those motions, would be greatly impaired. And think about how many ADLs we do with our shoulders abducted, right? Brushing our teeth, brushing our hair. All right, we do this a lot. We go into that motion, so that's big. That is literally all of the nerves that you need to know within the brachial plexus. And it's just going over the scapula, the motions within the scapula, and then we just talked about the chest area, the back muscles, the shoulder. All right? But we have to understand this and respect it. When you start with a blank slate, it is not scary. You start with your 3 Ys, you draw your 2 Ms, you make your 1 X, right? And then you just start filling in those nerves, and you just keep taking it back to function. All right? Dorsal scapular nerve, scapular retraction. Long thoracic nerve, scapular protraction. Nerve to subclavius, depression of the subclavius muscle. Okay? Suprascapular nerve, again, does innervation for internal and external rotation, infraspinatus and supraspinatus. Then we start to have that lateral pectoral nerve for pec major. And if there's a lateral pectoral nerve, we jump down to our medial pectoral nerve, which does both pectoralis major and minor muscles. We then have our 2 only skin, all right, they don't do any muscles. They're the only 2 in the brachial plexus that are unique. Medial brachial cutaneous nerve for the skin on the medial aspect of the arm. Medial antebrachial cutaneous nerve for the skin medial aspect of the forearm. Done. Now we just come into this middle. This is that posterior cord where we have our upper subscapular nerve, innervating the subscapularis muscle for internal rotation. All right. Then we have our thoracodorsal nerve. Here comes those back muscles, latissimus dorsi, thoracodorsal nerve. And again, if we have an upper subscapular nerve, we have a lower subscapular nerve. And here it is. And that innervates your subscapularis muscle, just like the name says, as well as teres major, which always works with this latissimus dorsi. And here they are side by side, working together, even though they got 2 different nerves. No problem. Axillary nerve, innervating the deltoid muscles and teres minor. Deltoid muscles and teres minor. Teres minor is just going back to that part of the rotator cuff muscles, and it assists with external rotation. External rotation. Our deltoid muscles, again, shoulder flexion, shoulder abduction, shoulder extension, and it assists with our internal and our external rotation as well. Then we have those big branches. We have our musculocutaneous nerve, which is heading down the arm. All right? We have that median nerve heading down that medial part of the arm, getting ready to do its thing down here in the forearm. Then we have that radial nerve dominating the posterior aspect of the arm and forearm. It dominates. It does it all. Great. And then we have that ulnar nerve, which travels all the way down, and really it hits down in the hand. It has a little bit going on the forearm, but ulnar nerve dominates our hand and gives us most of our hand function, power grip, power pinch. Again, that's another video where we'll talk about these 4 nerves, but that is, again, how easy it is to draw the brachial plexus. And mnemonic that I have learned that works for people, I will pass it along to you. Reach to drink cold beer. Reach to drink your cold beer. After spending a lot of time learning the brachial plexus, you might just want to reach to drink some cold beer, just to give your mind a little bit of a break. But that's how you have your roots, trunks, divisions, chords, and branches. The mnemonic, again, is reach to drink cold beer. And that can help you kind of process that and understand that a little bit better. I really hope that this has been helpful. I firmly believe that if you can understand the process of the anatomy and how it all comes together, you will be able to answer any question. You will understand anything as far as your school tests, your MBCOT exam, anything in the clinic, because you will understand the process of how everything's working together. If you just memorize, it is hard to think clinically, okay? But if you take the time to understand the process, you will be unstoppable. I mean it. You will be unstoppable. You'll be the best therapist that ever hit town. So take some time. Draw your 3 Ys, your 2 Ms, and your 1 X. Draw your 3 Ys, your 2 Ms, and your 1 X. And then just start filling in the blanks with those nerves. Start filling in the blanks with those nerves. Okay? Hope this is helpful. Good luck.